So our first speaker is Dr. Mark Wicclair. Dr. Wicclair is professor of philosophy and adjunct professor of community medicine at West Virginia University, where he's won 5 awards for outstanding research, teaching, and public service. He's also adjunct professor of medicine at the University of Pittsburgh Center for Bioethics and Health Law. Dr. Wicclair is the author of 2 books, Conscientious Objection in Healthcare and Ethical Analysis with Cambridge University Press, Ethics in the Elderly with Oxford University Press. He has a number of publications and articles on conscientious objection in healthcare, futility, managed care, decision-making capacity, advanced directives, surrogate decision-making, and the ethics of decision-making in critical care. He's also written an article and a book chapter on the television series House MD. I don't know if he'll be talking about that today, but maybe ask him about it. He serves on several ethics committees, and he's co-chair of the University of Pittsburgh Medical Center Committee on Research Involving the Dead. His talk today is Conscientious Objection in Pediatrics, to accommodate or not to accommodate. Please join me in welcoming Dr. Wicclair.
Well, thank you, Maureen, for that very nice welcome. She was kind enough not to say that I'm going to leave you in moral distress, and then Cinda will relieve you of that moral distress. I want to thank Doug and Ben for inviting me. Really was very, very pleased to be invited. I enjoyed yesterday's session, and I want to thank them and the committee for inviting me to talk here today. So I want to begin by saying a little bit about the concept of conscientious objection in healthcare. And first, what's very important to keep in mind is that there are a wide range of reasons that people can have for objecting to providing a service or a good or service. And when people have a conscientious objection, as the term suggests, it's an objection that is conscience-based. And conscience-based refusals, or CBRs for short, are based specifically on a clinician's moral beliefs. So they can be secular ethical beliefs or religious beliefs. So here's just a few examples of conscience-based objections. I'm sure we're all familiar with these. So some are related to reproduction, and clinicians have objected to providing or participating in abortion, sterilization, contraception, and assisted reproduction. Then there are conscience-based objections related to death. So some clinicians have an objection to foregoing life-sustaining treatment, sometimes specific measures. We'll talk a little bit later about foregoing medically provided nutrition and hydration. Clinicians have had conscience-based objections to providing palliative sedation to unconsciousness, and then more recently, objections to participating in donation after cardiac death. Then there are conscience-based objections related to research. Embryonic stem cell research has been a, no pun intended, fertile ground for conscience-based objections. And conscience-based objections related to human genetics, objections to various types of genetic testing and counseling. Now, just to be clear that we understand that, again, conscience-based objections are a very specific kind of objection or refusal. Let me just give some examples of objections, refusals that are not conscience-based, that don't involve conscientious objection. So one would be a clinician might be concerned about harm, injury to himself, herself, or his or her family. It could be a concern about contracting an infectious disease. Back many years ago, some of us are probably too young to remember, but clinicians were refusing to treat patients who were HIV positive. More recently, physicians might refuse to treat patients in various epidemics like SARS or Ebola. Unfortunately, some providers who provide abortion have been subject to violence, have been killed. So a clinician might refuse to participate in abortion, not because they're ethically opposed to it, but rather because they want to protect themselves and their family. What we're probably seeing more and more of is refusal to provide services based on low reimbursement rates. So some clinicians now are refusing to treat patients who are on Medicaid, and some are also refusing to treat patients on Medicare. That, again, is not a conscience-based refusal. Another instance would be a clinician determines that providing a service, could be intensive care, intubation, dialysis, is medically ineffective is the term that's sometimes used. It's pointless. It won't benefit the patient. That would be another example of a refusal that is not conscience-based. And then surgeons might refuse to provide surgery, again, not because they're morally opposed to it, but rather because they think that the tumor is, quote, inoperable. Another possible reason for refusing is the belief that a service that's being requested is either illegal or it violates norms of professional integrity. So, for example, in states other than Washington, Oregon, and Montana, physicians might refuse to participate or perform an abortion, not because they're morally opposed to it, but because they don't want to violate the law and they don't want to expose themselves to that kind of jeopardy. Another example, and this is more the norms of professional integrity, a provider might refuse to give steroids to a high school athlete, again, not because of moral objections, but rather because thinking that that violates the norms of professional integrity. So generally, conscience-based refusals are limited to situations in which clinicians refuse to provide a good or service that is legal and professionally accepted, and it's within the scope of their competence, because providing that good or service is contrary to their personal moral beliefs. I should point out, by the way, that that's another reason that clinicians might refuse to provide a service that's not conscience-based and it's not within their area of competence, or they think somebody else can do it better. We heard about that yesterday a little bit. So what I'd like to do is focus on two cases that involve pediatric patients, and then see whether we can kind of talk a little bit about guidelines for approaching these two cases. So the first case is a case of a adolescent who presents to an emergency department after being raped, and the emergency room physician who is on service refuses to provide her with information about emergency contraception. And I just added there that dispensing emergency contraception, this isn't, for example, a Catholic hospital, dispensing emergency contraception is consistent with hospital practice and hospital policy. The second case is an ICU case involving Nathan, who is a preterm infant. He doesn't require ventilator support anymore, but he is receiving medically provided nutrition and hydration. There's now a medical consensus that Nathan suffered a grade 4 bilateral intracranial hemorrhage that has left him neurologically devastated. So there's no disagreement about the clinical situation. Withdrawing medically provided nutrition and hydration with parental consent would be consistent with hospital policy and with the American Academy of Pediatrics guidelines. But the intensivist who is caring for Nathan has a conscience-based objection to foregoing medically provided nutrition and hydration, and the intensivist refuses to disclose the option to Nathan's parents. So the big question in cases like these is, well, do you accommodate the clinician who has the conscience-based objection? Do you allow the clinician to refuse to provide the service, or do you not accommodate? And I'd like to begin with a little bit of an editorial statement here, what I call simplistic answers, two extreme positions, two answers to this question, which are, I think, simplistic, and then I will try to argue for what I think is a more nuanced and more acceptable approach to these kinds of cases. So the first approach is basically, well, it's very simple. The answer is very simple. Don't accommodate. And why not? Well, because you generally should not accommodate people who have conscience-based objections. Basically, and I think this is aptly labeled the Incompatibility Thesis, and that's the thesis that refusing to provide a service that is legal, that's professionally acceptable, that's in your area of competence is a violation of your professional obligations. So then the answer would be very clear in both cases 1 and 2, no accommodation. The second extreme is just the opposite. Well, again, it's very easy. The answer is very easy. Whenever somebody has a conscience-based objection, then accommodate, protect their moral integrity. Now, just to kind of demonstrate, I'm a philosopher, and philosophers like to come up with completely unfactual, kind of hypothetical science fiction examples. So just to show you that I didn't invent this, these aren't straw persons. Here's a couple of examples of each of these views. So first, the Incompatibility Thesis, and this is in an article, a very well-known article by Julian Savulescu. If people are not prepared to offer legally permitted, efficient, and beneficial care to a patient because it conflicts with their values, they should not be doctors. Now, this is political season, and lots of folks are ripping statements out of context. So in fairness to Julian, I should say that although this is directly from his article, he does go on to qualify it somewhat. But this gives a very clear example of that view. Now, a statement that is not qualified at all is a New York Times editorial several years ago, which is about pharmacy, and it basically says, any pharmacist who can't dispense medicines lawfully prescribed by a doctor should find another line of work, go into philosophy if you can't fill prescriptions that doctors have written. The other extreme, this is actually most of the conscience clause from the Pharmacists for Life International, an organization, and here it is. So the rights of conscience of any person being a duly licensed pharmacist who shall object on personal, ethical, moral, or religious grounds to the performance of, and I've emphasized, any act in the normal course of professional performance or dispensing shall be respected. Further, as if that weren't enough already, further, such a refusal to perform any act or the omission of any act based on such a claim of conscience shall not form the basis for any claim for damages or any recriminatory or discriminatory action against such a person. So again, if we took either of those positions, the answer to both of those cases would be very straightforward, very simple, very clear. So now what I want to do is identify some problems with each of these two extreme approaches. So, problem with conscience absolutism. The major problem with that is that it overlooks the fact that healthcare professionals, nurses, physicians, pharmacists are, after all, professionals. And as we heard yesterday, professionals have special obligations. And the core professional obligations, and I think this, I've looked at various professional codes in pharmacy, nursing, and various medical codes, professional associations, and they all seem to agree on these kind of three core special obligations of clinicians in those various professions. So an obligation to respect patient dignity and refrain from discrimination, an obligation to promote patient health and well-being, an obligation to respect patient autonomy. By the way, does this time mean that I only have 15 minutes left? I thought I had 45 minutes. Yeah. Okay, but what does the time mean then? I was going to just... Okay. Whew. Where was I? An obligation to give speakers the allotted time, right? Okay, an obligation to promote patient health and well-being, and an obligation to respect patient autonomy. Now, since I'm a philosopher, I feel obligated, that's my professional obligation, to say, well, there is some moral foundation for these obligations. It's not just that they're written somewhere and you say, like you say to a 4-year-old, it's because I say so. So there are a number of different accounts that could be given of these obligations. One is that, well, those obligations stem from the nature of the profession, the goals of that profession, the nature of the client provider relationship. In medicine, there's a view that's referred to as the internal morality of medicine. So that would be one basis for supporting, deriving these obligations. A very common one is the social contract, or what Norm Daniels calls negotiation model. So these obligations basically arise in an agreement between the profession and society. You, the profession, have certain privileges, you have certain rights, but you also, in exchange for that, have certain responsibilities. A different view of that is reciprocity. It's based on the same notion that clinicians have certain rights and privileges, but now the argument is not that there's a negotiation, the social contract, but it's rather, well, it's a matter of your debt. Since you have these rights and privileges, you owe society, or you owe patients, or both, certain obligations in reciprocity for those benefits that you enjoy. And then finally, getting to the individual provider, it can be said that when one enters a profession, one assumes either tacitly or explicitly those obligations. That's part of what it means to enter a profession. Now, another problem with conscience absolutism is it doesn't consider the effect, the impact. I mean, it does, as I pointed out earlier, one has to consider the impact on patients, but you also have to consider the impact on your colleagues, on the institution, et cetera, et cetera. And conscience absolutism does not consider all of those other factors. So what about the incompatibility thesis? Well, the problem with major problem with the incompatibility thesis is it's just treating professionals as members of a profession, and it's overlooking the fact that in addition to being professionals, they are also human beings, they are also moral agents, and it's overlooking that moral agency. And it's failing to consider that moral agents have a sense of moral integrity, so it's not making any accommodation for moral integrity. Now, basically, moral integrity, at least as I'm going to propose it, involves three components. First, that a person has some very important core moral principles. Second, that these core moral principles or beliefs are so central to that person that they're really part of that person's self-understanding. That to act against those would be like acting against who you are. It would be a violation of your personhood. And then finally, applied now to refusal to provide that service that's being requested would violate your moral integrity. It would be against your moral beliefs, your core moral beliefs. So very quickly, why protect moral integrity? Several reasons. First, for many people, having moral integrity can be a very central part of their conception of what it means to have a good, meaningful life. Second, if one violates one's core moral principles, one can feel guilt, remorse, shame, and one can have a loss of self-respect. At least some have claimed that if one violates one's moral integrity, if no accommodation is made for one's core moral beliefs, that might have an impact, a wider impact on one's kind of moral commitments. It might shatter the kind of the moral fabric of one's personhood. We heard about respect for persons yesterday. Well, it's I think it's arguable that respect for persons requires also respect for moral integrity, not just respect for autonomy. Now, this is a little bit more controversial, but I think at least a claim could be made, plausible claim could be made, that having moral integrity is something that's intrinsically valuable, right? Again, thinking of our political environment today, the lack of moral integrity is something that at least a lot of people think is a sad thing. So it's not just that we admire people who have our own moral beliefs, but we admire people who have moral principles. Now, there are limits to that, right? I don't value Stalin for being true to his core moral beliefs, or Himmler. So there are limits to that, obviously, but I'm saying within a certain range, we don't just evaluate people on the basis of the content of their beliefs, but having moral principles, being true to them, is something that is valuable. Now, there are other reasons. So far I've just concentrated on moral integrity for why we should accommodate, but there are other reasons. This is epistemic modesty. Now, this isn't to be confused with relativism or skepticism. This is rather the view that we can believe that there are answers to ethics, right? I mean, widespread, there are no right answers. Well, you say, no, there are right answers. But we may not know those answers, right? Have you ever been mistaken about a factual question? Well, we can make mistakes. Well, we can also make mistakes about ethics, so we should keep that in mind when we determine whether or not to accommodate people. Secondly, in history of, the world and also medicine, you could say that certain people who have been sort of moral outliers at a certain time are the people that actually have set the tide for moral progress. So let's keep that in mind when we determine whether or not to accommodate people. Then there's also, some practices are just downright controversial. And that's another reason to accommodate people, at least with respect to certain kinds of procedures like abortion and palliative sedation to unconsciousness and DCD. Another reason is, toleration and accommodation promote diversity in the professions. If we didn't accommodate people with different beliefs, who came from different cultures, who came from different religious traditions, then that might be a very big disincentive for those people to join the profession in the first place, and the professions would become very monotonic, and that's not a desirable thing. We want diversity. Now, what I want to do, I hope I've given you at least enough reason to think that both of these extremes are problematic. And what I want to recommend is an approach that steers us somewhere between those two extremes, and I'm calling that reasonable accommodation. Now, the general aim of reasonable accommodation is basically to have your cake and eat it too, and that is to accommodate the clinician who has the conscience-based objection, at the same time, though, not unduly compromising the other interests, the interests of patients, colleagues, et cetera, et cetera. Now that, I can't imagine anybody would object to that aim. The problem is the devil's in the details, so how do you do this? And I want to suggest these guidelines. And then what I want to do is go on to apply these guidelines to the two cases. So first, sort of an advanced warning provision. So insofar as a clinician has these core moral beliefs and can anticipate that these core moral beliefs are going to put that clinician in a position where they may very well have to refuse a legal, professionally accepted, et cetera, et cetera, et cetera service, they should notify either patients or supervisors in advance. Second, the accommodation shouldn't impede a patient's or surrogate's timely access to information, counseling, and referral. Right, so that's going to be a constraint on accommodation. That has to do with information. The third has to do with the actual medical service. So accommodation shouldn't impede a patient's timely access to healthcare services. And finally, a constraint with respect to the impact on other professionals, colleagues, the institution, etc. So let's apply now these guidelines to those two cases. So the first guideline has to do with advance notification. So with respect to the first guideline, obviously, in this case, it's an emergency situation. A 16-year-old comes in after having suffered a rape. The emergency room doc couldn't have notified her in advance, right? But the emergency room physician could have and should have notified the department head that I am not going to be able to provide information about emergency contraception. The second case. Again, it's not clear in the second case, that's Nathan, it's not clear that advance notification of parents would have been possible. Maybe, I suppose it depends on the staffing of the intensive care unit, but certainly the clinician should have informed the head in advance of his inability to withdraw medically provided nutrition and hydration. So the second guideline, and this refers to a constraint against impeding the patient's or the surrogate's access to information so they can make an informed choice, so they can make an informed decision. So in the first case, any accommodation that is made to the emergency room physician would have to be such that it would not result in the rape victim not being informed, sorry about my negatives here, not being informed about the availability of emergency contraception. Now, there are studies that report that a considerable percentage of women are unaware of the of emergency contraception. They think if you're pregnant, if you've been raped or you've had sex, it's too late. You can't do anything about it. So it's crucial to give information to these patients. Now, if the emergency room doctor says, well, I can't disclose that information, it might be possible to accommodate by saying, okay, you don't have to. And of course, this is now context dependent. We heard a lot about that yesterday, but this is a very clear situation where it's context dependent. If there are other emergency room docs that are always on service, then this particular physician could make sure that the patient gets the information from someone else. Now that to me would be satisfactory, as long as the adolescent gets that information in a timely fashion. It doesn't have to be from that particular person. Now, what if the emergency room doc says, but I can't do that because that would be complicity in a moral evil? And my view is, well, that's too bad, right? Because there are constraints on what can be done to accommodate conscientious objection. Right? And that's why I reject the extreme of conscience absolutism. Now, similarly in case 2, it might be possible to accommodate the physician. Again, that's contextual. It depends on what the staffing is like in this particular ICU. But again, the important thing is that whatever accommodation is worked out, it cannot result in the parents not being informed of this option. That is a basic factor. And again, if the ICU doc says, but I can't tell him to go see Sarah, because if I tell him to see Sarah, then that will involve me in this thing, and that violates my moral conscience. And I say, well, I'm sorry, there are limits to accommodation. And just sort of a little bit of levity here. This is how not to satisfy the second guideline. I don't know, can you read it, or is it readable? Okay, then I'll let you read it while I have a glass of water. I mean, I realize that probably a lot of you, when Maureen referred to my work on House MD, you would have preferred a presentation on House MD. Well, this is the best I could do to have a little bit of laughter, at least. Okay, so the third guideline. This is accommodation shouldn't impede the patient's timely access to health care services. So to apply this to case 1, again, this is contextual, depending on the staffing in this emergency department, depending on, the availability, I think it's really depending on the staffing of this emergency department. Is it possible to refer the patient to someone else so that she will get timely access to emergency contraception? It might be possible. But it's probably going to require that the first physician do something to facilitate that. Now, there's kind of a very extreme case of a pharmacist who was accommodated to the extent that all the pharmacist had to do if he ever had a request for emergency contraception, or I think this was any contraception actually, all he had to do is put the script in a basket for somebody else to fill. And if he got a phone call, he could put it on hold and have another pharmacist take that phone, if the phone call were for contraception. But he refused to do that. He said, no. So what he did is he put the phone on hold and walked away from the phone. Now that is blocking the person's access to the service. And that, at least is what my argument, that is the limit to accommodation. And this similarly applies to case 2. Somebody has to be there to provide that information, and the emergency room doctor who has the conscience-based objection has to be at least willing to facilitate someone else providing that information to the parents. The 4th guideline. Accommodation shouldn't impose burdens on other professionals, colleagues, the institution, et cetera, et cetera. And again, now this is clearly, context makes it clear how deciding whether or not to accommodate is not a simple matter. You can't just say yes, no. You have to say, well, it depends. And one of the things it depends on is what are the options within that particular institution for having other people available to provide the information or to provide the service without undue burdens. Now, you ask me what's an undue burden, and if I could answer that, I would be rich and famous. But the point is, you'd have to consider that, and that's why it's not just a simplistic yes or no answer. So in case 1, well, again, if there's more than one ED physician always in service, and they have enough, so that they're never going to be in a situation where this particular physician is going to be the only one, then it's okay. But if there's a night where this particular physician can't get anybody else to provide that information, then that physician has an obligation to provide it himself. And similarly in case 2, if it is impossible without putting, burdens on people, I mean, sure, if you put all the other people on call, it would be possible, but that's an undue burden. It's not reasonable to expect other people to be on call 24/7 to accommodate somebody's conscience-based objection. Okay, philosophers always like to be, we're going to have a discussion period. Lots of people are going to object, but philosophers like to pre-object, right? And then respond to the objection so there's nothing left for you to say, right? So, this is, I think, the primary objection to my approach, to this middle, trying to strike a balance between the 2 extremes. And that is, somebody could say, well, look, reasonable accommodation may be fine, it may be reasonable, but it's not enough, because as I've very honestly, clearly indicated, in certain situations, certain contexts, it may require clinicians to violate their moral integrity. Okay, so response. Well, as I've indicated, clinicians assume certain special obligations when they enter a profession, and they have to honor those professional obligations. And if honoring them means, in this particular situation, they have to violate their moral integrity, then so be it. That is their obligation as a nurse, as a physician, as a pharmacist. And the other thing to keep in mind, which distinguishes healthcare from, let's say, the military draft, which fortunately there isn't one anymore, but when people were conscientious objectors to military service, they were drafted. So they had no choice. It wasn't to say, well, they had a choice. They could go to Canada. But they didn't really have a choice. If they were American, at that point, men within a certain age, they would be drafted. But people have choices of professions. They have choices of disciplines. They have choices of practice environments. And so with a little bit of foresight, you don't have to, I mean, if you can't provide information about emergency contraception, you don't have to go into philosophy. You can go into an area of medicine, or you can practice in an environment where you might be able to be accommodated. So I'm suggesting that it's a little bit of a prevention here to think ahead. So it's not just advance notification that's important, but also to think, well, I have these beliefs, and can I choose a sub-area within medicine and a practice environment where I'm more likely to be accommodated than in some other area. Now, finally, and this I think is a little bit controversial, but I think that if we really take seriously what I think is the primary reason for accommodating conscience-based refusals, and that is respect for a person's moral integrity. That pretty much puts very, I think, severe limits on the kind of inquiry we can make into people's moral beliefs. And we can't hold them to a very high standard of being able to justify their moral beliefs or having good reasons versus bad, because that's, again, that's the whole point of accommodation, protecting moral integrity, is giving people moral space. So I at least want to suggest that in order to give people moral space, we should be fairly lenient in terms of our a requirement that they be able to present reasons, present justifications, in contrast to what was the case with conscientious objection to military service. Men who claimed CO status were grilled by their draft boards and had to provide very specific reasons or it was rejected. Okay, but there's always exceptions to every rule, right? So I think there are at least 3 exceptions to this general notion, give people moral space. One is if a refusal is based on invidious discrimination. I think in all professions, it is recognized that invidious discrimination is wrong. And there are good moral reasons for it, for respecting people's dignity, personhood, et cetera, et cetera. So I think that would be one constraint. And here kind of the red flag would go up if a clinician isn't refusing to provide a service, but they're refusing to provide a service to this person. Right? I'll provide reproductive services, but I won't provide it to people who aren't married and are of the opposite sex. Or I'll provide, I don't know, I'll provide emergency contraception, but not to people of a certain race. So that's the red flag, is if somebody is prepared to provide a service to other people, but not to people of a certain class. Oops, too quick on the trigger finger here. Now, this one is also controversial, but I think there are at least some cases, maybe very rare, maybe just science fiction, where you could make a case that the refusal to provide a service is just so contrary to the goals of that particular profession. And an example that I have that at least an informant told me is not fiction is of a family practitioner who, long after going into practice, became a Buddhist. And he, at that point, refused to provide any pain medication to patients because he thought pain was part of a person's karma, and providing pain medication would just keep that person on the wheel of rebirth and would be a harm to that person. Now, I think that any person who believes, for whatever reason, that pain should not be alleviated should not go into medicine, right? Then I would say go into philosophy. Or go into pathology, right? Go into pathology. And then finally, refusal is based on demonstrably mistaken clinical beliefs. And again, demonstrably mistaken, There are some examples in the literature of pharmacists who have just completely mistaken beliefs about the mechanism of Plan B emergency contraception. It's shocking how pharmacists would have just basic misinformation about the mechanism of emergency contraception. Now, if the situation is such that if the pharmacist understood the mechanism of EC, and then they say, oh, well, in that case, I have no objection to it, then that would be an instance where the objection is based on demonstrably false clinical beliefs and should not be accommodated. Okay, finally, everybody's favorite slide, the conclusion. What I've tried to argue is that the two extremes, the two simplistic answers to the question accommodate or not accommodate, they're both unacceptable, and that whenever feasible, clinicians' conscience-based objections should be reasonably accommodated. And a reasonable accommodation would preclude impeding the patient's or surrogate's timely access to information and would place information and the service, and in addition would impose undue burdens on other professionals or the institution. Ooh, and I have 11 seconds left. Thank you.